I lost my dongle. Did you know this is called a dongle? I did not know it's called a dongle. I did not make that up. I also did not know that the A with a circle around it is called an ampersand. Did you know that?
What?
The A with the circle around it is called an ampersand. I was
knew
like,
that 'cause it's
somebody
a
made
fun
that
word.
up. Out of everything I learned in my bachelor's, that's the thing that got stuck in my brain. I was pretty sure my teacher was making it up. When you have an A with a circle around it on your keyboard, it's called an ampersand.
Because I think it's like
Jane was like, did you go to happy hour? You're on break. What the hell? Just kidding. What'd you say?
I'm pretty sure it's like a combination, or at least how I learned it was it's a combination of a and per se and
There
and
you
that's
go.
where ampersand came
See?
from.
Trivia. I learned all kinds of stuff today.
That's how I learned it at least.
Okay. So again, guys, we're going to reintroduce why we intubate people and why we have to manage their ventilation. And then looking at some ABGs and how to correct them, we're gonna start back on this. So coming up in the next week, we're gonna be practicing how to fix people's blood gases with ventilation. We need to look at the alveolar air equation again, some oxygen content and estimated shunt equations. You guys have had all this before, which means you're in a much better position than the class below you because they lost 2 days. They were not introduced to any of this. So guess what fun they get to have in mechanical ventilation. Okay, so the number one reason somebody buys a tube and goes on a ventilator is because they coded, they had an arrest. Oh, sorry, I had a tutoring schedule, if you want to send it for me. Everywhere that it says what time, that's when I'm available. You can look at that, okay? All right, so anytime somebody stops breathing for 20 seconds, that is technically apnea. In a child, how long do I get to wait? And in a baby? 10. That's right. Okay, so you're apneic at that point. Does not necessarily mean you run in the room and drop a tube. However, I do need to figure out what's going on. A code is a critical emergency. That's what happens when somebody's heart stops or they stop breathing. Our resuscitative efforts include a lot of different phases. And it depends on if somebody is a full code, DNR, DNI, get the hell away from me, whatever it is you want to say. My little 94-year-old grandma, was I telling you about her? Made me ill. The lady with the bed bugs. Yeah, super disturbing. She got to buy a tube unnecessarily because she should have just went to meet Jesus full of COVID. Now she has a pneumo, she bought a chest tube. All right, so acute respiratory failure is defined as a pH of less than 7.25 with a CO2 of 50 or greater, and a KO2 of less than the patient's normal on-room air. And that is the ceiling title for respiratory failure. As we talked about remediating your tests, you have 2 types, hypoxemic and hypercapnic, okay? Respiratory failure happens when a patient is not able to maintain adequate gas exchange. And again, there's millions of reasons why that won't happen, right? If I drug the crap out of you, I'm gonna make you stop breathing, okay? If you overdose yourself in the street, you will stop breathing. We're gonna fix this with intubation and mechanical ventilation. And again, we have hypoxemic and hypercapnic. So what I'm gonna build into your lab assignment tomorrow to work on when you're not on event is I'm gonna give you blood gas. I'm gonna have you name it and tell me whether it's hypoxemic or hypercapnic or both, okay? So hypoxemic simply means normal, 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 ugly, okay? Hypercapnic, normal, ugly, ugly, okay? With or without a compensation. I also can have somebody who's both. And in fact, I bet you more money than I have. Most of the patients you've seen now have been a mix, right? They certainly had more than one kind of respiratory failure. So questions about hypoxemic versus hypercapnic, you'll practice this tomorrow, okay? So again, in hypoxemic respiratory failure, we only have an issue with the PO2. We fix it by giving oxygen, and that is the number one way to fix it and the easiest way to fix it. But the bottom statement here is our rule, right? So if I've given up to 60% FiO2 and I haven't fixed it, my little sad alveolus is not touching the capillary bed. I need to give it some pressure. I need to add CPAP, EPAP, or PEEP. must fix it. But in the scheme of things, our 4 life functions are ventilation and oxygenation in order of top to bottom, right? I don't correct oxygenation first if I have a ventilation problem. If I have a respiratory acidosis, that trumps everybody. Okay, you fix that first. Now, logic would tell you if I fix the ventilation, I will probably improve oxygenation as well, right? And you've seen it, right? If you put somebody on BiPAP, everything gets better across the board. But for your board exam, you have to do it in order, okay? So if they only have hypoxemic respiratory failure, well, then I fix that. If they have hypercapnic failure, I'm gonna have to fix that first, okay? Now you guys know you don't have a whole hospital full of ventilators, right? Not everybody needs to be ventilated. Lots of people are just fine on just oxygen, but you have to do it methodically with the boards, okay? So some causes of hypoxemic respiratory failure are going to be related to a VQ mismatch, such as any kind of diffusion defects like emphysema, alveolar hypoventilation like our RZ COVID folks, people who have pneumonia, people who are underventilated because we set the vent up stupid, okay? People who have alveolar collapse because we picked their target volume and we went with the super low side of that. It can happen. Somebody we don't have an adequate respiratory rate set for. Now, as we get older, we are just not as efficient as a being either. And we will become hypoxemic as we get older just by nature, okay? A right to left shunt means blood is getting to the lungs without being oxygenated. So in other words, I'm sorry, it's bypassing the lungs without being oxygenated. That's a shunt. Now the rare odd case that somebody is at super high altitude like Mount Everest, or they're in a plane, or they're an astronaut, they could have an inadequate inspired oxygen situation happening, but that's super rare. Super rare. What's not rare is if you're involved in a house that's on fire and all the oxygen is being sucked up. Okay, that could certainly set you off with a hypoxemic respiratory failure. And that is why our patients who have been in a fire, I don't care if the saturation says 100% on your oximeter. Why don't I care? What's happening with the hemoglobin?
Carbon monoxide poisoning.
Carbon monoxide has blown every O2 molecule off of that hemoglobin molecule. I gotta have help. So I need to put you in hyperbaric if I can, get you 100% oxygen at the very least. So it does not matter if I'm perfectly cherry pink and my finger says I'm 100%, don't believe it, okay? What might it look like? Well, I'm probably gonna be tachypnic, dyspneic, could be pale or blue, right? Cyanosis is a late sign. You're gonna have peripheral vasoconstriction, so it's gonna be harder to get a sac because your body shuts down. Your body's designed, and you guys learned this last class in 241, right? What happens when there's a trauma or an injury? What does your body do with your limbs and your feet? It shunts all the blood to your core, right? It's like, I don't need this hand, I don't need this foot, I need blood in my core, so it's gonna shunt everything to the center, okay? Sometimes people get restless with this. Disoriented is a big one, headaches, and they can be lethargic. So anytime somebody is in a hypoxemic respiratory failure, they're gonna be looking something like this. Now, if you've ever had a migraine and you had oxygen available, it fixes it magically, doesn't it? Yeah, when I used to work at the old job I had, that's when I was getting a lot of migraines and I didn't have medicine for it yet. I would just go put O2 on, fixed it all. Like, it's amazing, it's actually wonderful stuff.
Bless you.
Other signs and symptoms, you will become tachycardic in the beginning, but eventually the patient will flip the other way. They'll become bradycardic as they start to get worse. They can become somnolent. What does that mean? What is somnolent?
Like sleepy, lethargic, but difficult to rouse.
But difficult to arouse. Whereas if you're just sleeping and I come in and I say, hey Diego, he'll probably wake up and talk to me. If you're somnolent, I'm gonna be like, hey Diego, and he's not gonna get up, okay? Confusion, blurred vision, loss of coordination. This is what happens to drunk people. Crashing into walls. Loss of consciousness, and you can revert into a coma.
Hypoxemic people do act like drunk people.
They do act very much like drunk people. Because you're not getting oxygen to your brain. Same thing when you're full of alcohol. Blood supply's not hitting your brain. Okay? Now, hypoxemia, so hypoxic respiratory failure, okay, is the last reason we intubate somebody. We don't intubate them just for that, okay, because we have other stuff. I can give you a high flow device. I can put you on a heated high flow system like the Airvo. I can put you on CPAP. I can do all kinds of other stuff before I have to drop a tube and try to ventilate you with high FiO2 and P, because that's really the last resort. Now, how many COVID people do you think we're intubating because of hypoxemia? More than I'd like to talk about, okay? Because once that happens, they're about this far into going into acute respiratory failure type 2, which is hypercarbic. No bueno, they die. So it's neighbor, hypercapnic, hypercarbic, whatever. Hypercapnic respiratory failure is a technical term. This is when you have a PaCO2 of greater than 50, but the PaO2 is normal. So I have an issue with my pH. I have a respiratory acidosis happening, but I'm oxygenating okay. This is probably because the respiratory muscles are weak. There's something wrong with your brain, the brainstem, to tell you, hey, dummy, you need to breathe. We have to fix this by intubation and ventilation. Now, because this is acute. This is normal, so I've had no time to jump in. This is not a COPD, okay? COPD, or say this was 34 instead, then I would try BiPAP first, non-invasive. That's a huge difference in the way the boards want you to handle how you treat people like this, okay? This guy's acutely ill, he gets to bi-event. If it was somebody who lives at 34 and now they're having an acute problem, I might get lucky with BiPAP, okay, or non-invasive, I could try that first. This guy gets tubed. Is that clear to everybody? Okay? So causes, well, anything that will depress the central nervous system, and a huge chunk of that is drugs. All those little people who are dying on the streets right now who are overdosing, that's what they're doing, okay? They're knocking out their ability to breathe. Now I didn't know her very well because I only met her a couple of times when I was at UNM, but one of the therapists there, this is going back 30 years, 28 years, killed herself in the bathroom. She took what she thought was morphine because the nurse had labeled the bag wrong, and back then the bags were just hanging, so it was like, morphine, good drugs, all kinds of stuff was just available in the room, and she had developed a drug habit. So she would go take a little bit for the patient, go in the bathroom and inject it. Well, this particular day, she took it off of the bag that said morphine, but it was really Nimbex, a paralytic. And she went in the bathroom and injected herself like she had done many times before and killed herself. 20 minutes, nobody could find her. They were looking for her all over, kept paging her. She didn't answer. They finally realized she was in the ladies' bathroom on that unit and broke the door down, and she was in there dead on the floor. Yep, happens. Now, people who have really bad obstructive or central sleep apnea can also have a problem with this. Metabolic acidosis can lead to ventilatory failure, right? Because I'm just breathing too fast. Neuromuscular issues, of course, my example of a paralytic, or any other time you have impaired muscle function. So think about somebody who's been in an accident and they have a spinal cord injury, okay? Remember what we said in your last class? The reason that people die in trauma is because of a high spinal cord injury and nobody there to breathe for them, okay? So chest wall issues can happen too, because if you think about somebody's chest wall, if it's not functioning mechanically like it's supposed to, I'm not going to be able to breathe. So if I've been in an accident and I got the right side of my rib cage kicked in, is that going to be doing too much good for me? You guys remember that picture I showed you of the flail chest, right? Where they had like 27 rib breaks, there was subemphysema everywhere. That whole part of the chest was not working. They had a big hematoma too. So anything that's happening like that, pleural diseases like pleural effusions, okay? Pneumothorax. Any other time you have an increasing airway resistance. And then something called cardiac-induced pulmonary edema. Because you get flash pulmonary edema. Some of you have seen it. You've been telling me stories. Where somebody's doing okay, all of a sudden they're blowing white foam all over the room, okay, or pink foam, and they have a history of CHF. Not good. So signs of hypercapnic failure. Well, gee, they kind of look the same. There's a lot of really similar signs of hypercapnic and hypoxemic failure. Okay, tachypnea, tachycardia, sure. Hallucinations, loss of consciousness, absolutely. Convulsions typically happen with hypercapnic failure as opposed to hypoxemic failure. But confusion, dizziness, headaches, all of that, doesn't matter what side of the failure you're on, you're gonna be presenting the same way. Okay? I would venture to say that the patients I've seen have more of a level of loss of consciousness or being super, super confused as they become more hypercapnic. And you've seen it, right? You've had patients who were fine at 8 in the morning, and then the nurse came in and gave them a bunch of morphine. You jump in at 12 to say hello, and all of a sudden they're out to lunch, like they checked out. Probably because somebody came and gave good drugs in between.
I had a post-COVID patient at AMG who they gave her oxycodone and some other, I think it was a nausea drug that you weren't supposed to give. Yeah, but apparently you weren't supposed to give those two at the same time, and she just stopped breathing. Like, she had to be put back on a ventilator after being off of it for a month, and I saw her ABG 120 CO2.
Nice, and her pH was 6.8 something.
Oh yeah, something like that. It was
Something
terrible.
Yeah, and that's a drug overdose. Now, it happens a lot because nurses don't know what they're giving. Now, the machines now, you walk in and you tell it, I want to have Brian have 10 milligrams of X drug. And the machine will say, are you sure? This is what we're doing. Do you really like it? Here's the calculation for it, so that they try to avoid some of these oversights.
Yeah.
But you have to understand the relationship between a narcotic, which is also depressing, and Phenergan, which will put you to sleep. If you've ever had Phenergan in this room, it's like some aggressive Benadryl. You're like, good night, don't care.
Yeah, and I think the issue was she was complaining of nausea, so she wasn't technically prescribed Phenergan, so it wasn't being given through the machine. It was just being given through the IV directly. That's probably why it wasn't caught.
Yeah, still not good. Now, we have evidence on blood gases that show we have one of two types of respiratory failure. But you guys have already seen patients that look like crap and have a pretty decent ABG, haven't you? Okay? That does not mean we don't need to pay attention, because just because it hasn't caught up to the blood gas yet doesn't mean they're not in trouble. And this is a battle that I have fought with physicians since I started, because they're like, oh, well, they're like, gee, he looks terrible. And then you run a blood gas and the blood gas is just about perfect. And I'm like, okay, well, give it an hour, because they're not going to be perfect, and you're going to be in here doing this emergently. So you have to kind of push on that a little bit and say, you and I both know he looks terrible, so can we just get the intubation done when we have a calm, cool, collected environment, rather than wait for the person to code and then we have to do it, okay? I'm lucky now because the physicians I work with at Loveland are very proactive. Like, if they think somebody's, especially in COVID, if somebody's going to look bad, you're buying a tube. Nobody even waits around anymore. But old school, especially, like the horror story you guys were telling me about Grants, that one patient they didn't want to intubate because the doctor didn't know how, or didn't want to, or was too busy fluffing her nails and whatever the hell she was doing, eating chocolate. God bless. I yelled at a nurse the other day for poking somebody's finger without warning them. Can you imagine what I would have done in that room at that time? I'd have lost my mind. I'd probably been fired. Where is your brain? But you are asked to do procedures you're not comfortable with, and the only reason you're going to get comfortable is if you keep doing it. And she went to Grants where she hasn't touched an ET tube in about 400 years. Yeah, stupid. Because she couldn't be bothered. She was too busy. I bet that poor man died. Did you ever hear?
He did.
He did die? Ugh.
He did?
Yeah, they flew him out to Arizona and he died. No, that was you that were with me that one time. Yeah. That's a different one. No, he did. He did. Oh,
There's more than one. That's so like I said, sometimes somebody doesn't look good physically, and you will develop these skills where you walk into a room and go, oh, that one's okay, oh, that one is not okay. And you'll know. Whether you can get a physician to buy into it or not, it may take some convincing. It may take your supervisor to help you, or a physician partner that you're used to working with to kind of get it done. But we still have to realize that even if they look okay right now, they are still going down the hill. They're still sliding down the hill. We have to stop it, okay? If I can head it off, I might be able to put you on a BiPAP for a little bit just because they gave you a little bit of something sleepy, okay? Now, with BiPAP or non-invasive, the patients have to be alert enough or at least able to physically move to rip the mask off their face. Because if they're going to puke in it, you don't want them to be strapped to it and they're tied to the bed. That's actually a contraindication for non-invasive.
So he was puking up blood.
Oh dear.
And then she had to take it off. It was just a big mess. But did he take it off? Or it wasn't fast enough?
He wasn't fast enough.
Yeah, he was in bad shape.
I've thrown up in an N95 and that's really hard to even get it off you that fast. I was like, I'm in COVID, I can't puke in COVID. So we have to prevent it if we can, okay? Another indication for needing to intubate, mechanically ventilate, or what you should worry about for impending respiratory failure is your poor respiratory bedside mechanics, okay? So MIP and MEP. So remember, your maximum inspiratory pressure needs to be at least -20. So your next quiz will have a question that says, you have a patient with Guillain-Barré. You checked him at 10 and your MIP was 40. And then you checked him again and it was 30. And all of a sudden now you're 18. So once you cross that threshold or get near 20, you have to consider doing some support, okay? MEP should be at least 40. That's minimum. Vital capacity is 65 to 75 mLs per kilo ideal body weight. Or, yep, vital capacity is 65 to 75 mLs per kilo ideal body weight.
Is that the normal value or the critical?
That's normal. Critical is 10. If you can't even do 10 mLs per kilo ideal body weight, we're in trouble. Now, some other people look at vital capacity as if you can do 2 times the tidal volume, that's pretty decent, right? But for the boards, 65 to 75 is normal. You have to be able to do at least 10. If you can't do 10, you're buying the tube, okay? Normal VD to VT ratio, which is your shunt, is about 20%. So you don't need all this review for interpreting ABGs, but I put it in here for the class I did over the internet because they hadn't thought about it in a long time. So we're not gonna cover this right now. If there's any questions you guys have, please let me know. This is all stuff you guys are doing really, really well at, okay? So normal ranges, what do we care? Look at the bicarb. Do we have something we can fix, okay? Now our chronic ventilatory failure people, this is our COPD patients, okay? They live and actually feel okay at a higher CO2 variant than the rest of us, okay? So if the pH is normal, I don't care. And I'm pretty sure you already know what I mean by these kind of gases, right? So chronic respiratory failure, but okay. Okay? I've compensated, that's where they live. I don't have to be so concerned about them because that's how they're doing it, okay? Now, acute respiratory failure, or hypercapnic respiratory failure, okay, would be something like that. Acute on chronic is your third example there. So an acute on chronic person, they are living at a higher elevated CO2. But now they're having something acutely ill happen, something's happening, or I'm gonna have to fix it, okay? The top one gets intubated by a vent. The middle one, that's where he lives, I'm not gonna worry about it. The third one, they're gonna go on non-invasive because this needs some help, okay?
How do you distinguish from acute on chronic and then the top one?
Whether I have an elevated bicarb or not. So there's no compensation happening right here, Ray, at all, but I have some happening here. That's how you tell.
Okay, so the middle one is the chronic.
Chronic but okay. Okay, acutely ill by a tube, chronic and okay, chronic and getting sick. Okay?
Acute on chronic, partially compensated.
Absolutely. Yep. So we call this a partially compensated respiratory acidosis, right? Which in this case the oxygenation is fine. Do you have a question?
Is there a reason why, like besides them full coding, where you would just completely skip BiPAP and immediately intubate them if they were chronic?
Yeah, so it depends on, like I gave you this number, it depends on what book you're looking at and Dr. O's mood sometimes. For me, this is pretty low, okay, but the boards want you to try to non-invasive this. My cutoff is 7.5 or less, because you're getting kind of acidic. But if you have not previously intervened, you need to BiPAP them, okay? But let's say I do BiPAP this person, and I put them on a BiPAP of 10/5 with like 40% or whatever, and I come back. And they now look like this. They're getting worse. Okay? I did something, they're getting worse, now they get tubed. Okay? And in this class, any of these classes, this whole program actually, for preparing you for the boards and blood gases, this is the part that's going to want to make you jump off the roof. Because the way they do stuff is methodical. It has to be done in a particular order. When if I walked in and saw somebody with this crappy gas, you're buying a tube. I'm not going to fight around with that, right? If you have this ugly gas, you're buying a tube, okay? This guy, it depends on what it looks like. If I see a real patient with this blood gas, I may intubate him depending on how he looks, right? If he's really struggling, but the boards are specific. So I probably shouldn't use this, put it at a 2.5. But like I said, it depends on the book you're looking at. For me, if you're under 7.25, you're probably buying a tube anyway, okay? You're watching next door, it sounds like Sesame Street.
It does.
Okay, so a couple examples of who needs to buy a tube. Okay, so again, uncompensated respiratory acidosis, you get to buy a ventilator all day. Okay, intubate, ventilate. Do any of you have any issues with that?
So
Huh?
are those are also considered hypoxemic?
They are. So this would actually be a mixed respiratory, mixed failure. They have two problems, okay? But we fix ventilation first, okay? Always fix ventilation first. That's that order of the life functions. You have to do them for the boards that way or you're gonna mess up. Here's somebody who's not amazing yet, but they're not really that sick. So these guys could buy non-invasive ventilation. Also have both types of respiratory failure, right? Okay? And unfortunately, most of our patients are messed up like this. Non-invasive. Now, by the way, for the boards, if you're starting BiPAP, they like you to start at an IPAP of 10 and an EPAP of 5, with whatever the lowest FiO2 is you get away with. 10/5 is a perfectly agreeable place to start for the boards.
So that's like that.
Right.
And what was the FiO2?
Whatever you need to get it at, but hopefully as low as possible. And again, let's just say that we have somebody who needs 100%. Do I really want to mess around with BiPAP? You're probably too sick. So,
So what if their PaO2 is like 65?
65, still ventilate them first. Still have to do non-invasive first. Maybe give them 40% at that time with that FiO2. We're going to start to practice a whole bunch of these rates, so you'll be doing them like this, okay? Now, there's a rare circumstance with our COPD friends where too much oxygen causes them to hypoventilate, okay? So, when I have a partially compensated respiratory acidosis, which is what this is, right? I need to look at the PO2 first. So before I do anything to increase ventilation, I have to look at this, because if this is higher than 70, that's too much. Remember I told you before, the COPD patient, obstructed chronic patients, have a PO2 somewhere around 55 to 65, with 70 being like the max, okay? This is too much. So rather than fixing ventilation first, I actually have to deal with this, and this is actually going to fix ventilation. Does that make sense? I gotta turn it down. So either turn down the FiO2 and get it below 60, or I need to take the PEEP down or the CPAP down, as indicated, okay? Same thing here. So the rule is, somebody who has a partially compensated respiratory acidosis with a normal to high PO2, because they're not supposed to live there, you need to fix that first. And again, we're going to be practicing these to death in this class. Sandra, you good back there? Like you're about to crawl under the table. Did your head go? Below, well, 70 is like the absolute max. It has to be, most of them live, Brian, between 55 and 65. So the key is anytime you see a PO2 over 70 in a situation like this, do something to decrease the FiO2 delivered. So there's a rule. Okay, we talked about this a little bit last time. So when you're going up on oxygenation to fix it, okay, I go up on the FiO2 till I get to 60, then I add or increase CPAP or PEEP, right?
Right.
I come down the same way. I'm gonna bring the FiO2 down first, because it's a drug, get it under 60, and then I can bring down the CPAP, because I want to recruit. That's right. That's right. We're gonna say that for today, because we're gonna learn in complications, there are rare circumstances where we have to do the PEEP first. I know, I'm sorry. I'm sorry. It's like, it's this, only if it's not a Tuesday under full moon when I have chili for lunch. I know, I hate it. I tell you, if I ever meet any of the people who actually write the board exam, I will walk up and slap them in the face. That's like people go, well, what are the normal ranges? And this is gonna drive you insane at this semester, because depending on what book you're in, like a range for, you know, hematocrit could be slightly different. So there's hacks for that though. So like if a hematocrit range is somewhere near 5, like it might be 3.5 to 6. Could be 4 to 6. It could be 3 to 6. Who gives a crap? It's 5. 5, right in the middle of 5. Because the boards are going to be so offline that you'll know it's an anemia problem. If you take your red blood cells, which are 5, multiply them by 3, you get your hemoglobin. If you multiply it by 3 again, that's 45. That's your crit. So 5, 15, 45. I don't care where the range is at. That's dead center. I'm going to learn that. Sodium. We talked about this, right? Dead center 140. I don't really give a crap what the book says or a book says, because they're all just a little bit different. Plus, if you go to a hospital, they're a little bit different. You've already noticed this, right? So what is my dead center point for that range for any known value? Whatever book you're playing with, go with that, because the boards are going to be so far off in either direction, you'll know it's wrong. Does that make sense? Because they're like, well, this book said this, and that book said that, and Kindred said this, and AMG had something else, and I'm like, I know. I know. So you can either remember some totally crazy large range that covers every gamut of every book you looked at, or you can remember the dead center point and go from there. Just easier. Okay. But I kind of want to think about what oxygen status is my patient really in. Okay, what are some of the things I need to look at to see how well they're doing? Well, you guys have already done the alveolar air equation, which is P big AO2, right? Mm-hmm. Making you want to cry already again. She's like, no, we're not, we can't do it. Okay, so there are a lot of variations for this formula. There is a hack for the formula, which is very nice to use on the boards. Dr. O will make you do it the long way, and there's 2 versions of that. Okay, they're on the slides coming up. So alveolar air equation is barometric pressure minus the partial pressure of water vapor. Well, that goes all the way back to oxygen therapy. Who thought about that? Yuck, right? Barometric pressure is somewhere around 760, depending on what state you live in. Okay? Partial pressure water vapor is about 47 normally. The boards assume that you know that. Okay? So make sure they're not going to tell you what the partial pressure of water vapor is. They're going to give you the other data that you need, but they're going to assume you know what normal barometric pressure is and what normal partial pressure water vapor is. So I just plug in what I have. I'll be given the FiO2, I'll be given the PaCO2, and then this particular formula divides it by 0.8. Barometric pressure on the boards is 760 unless otherwise stated. If they want you to use something else, they will tell you.
So the board's just assume we're all at sea level?
That's right. That's precisely right. And that's what's happening with your blood gases, right? Up here, if we drew gases on all of us, we all don't have PO2s of 100, not in Albuquerque. Okay? You know, but who feels amazingly well when you go to sea level? Like, who goes to the ocean and you're like, I can breathe, life is so great. I tell my husband, I'm like, we were gonna move to South Carolina just because I could breathe. Like, it was amazing. We hiked. I actually, eating as much as I did like a pig, I lost 10 pounds there because we walked every day. I'm like, I can breathe, it's magical. Who knew? And we ate, oh my God, you should see what we eat. We ate, like if it was seafood and it was not nailed down, it was mine. Well, I never had shrimp like that. Like this seafood there is so fresh. It was quite amazing if you never got.
Took my husband to Chicago back in May, and he's a type 1 diabetic.
Oh yeah.
And he went down to sea level, and he was like, holy crap, everything was different for him. So his sugars were low.
Yeah.
He was having the time of his life. He's
Oh,
like,
yeah.
we're moving here just because I can breathe and I feel great
Yeah.
and I'm able to move. And I was like,
Yeah, that was the other thing. My joints didn't hurt. Like it was like, oh, it's just amazing. I'm like, oh, we need to move. My husband and I are joking around about moving. Okay, now another alternative equation for this, and it just depends on how you feel about the math. Okay, I would much rather multiply something than divide it because I hate dividing. Completely up to you. Okay. Now the board. It sounds like you're allowed to use the calculator on the computer now. This is the first year that's happened. So my students are telling me that yes, you do get to use the calculator. So however you want to do it is okay. That one's easier for me. Okay, the third one down is a hack. Now, the hack part of it, I'm going to take the number 7. I'm going to times it by the FiO2 as just a whole number. It doesn't have to be decimal, just as the number. Minus the CO2 plus 10. You'll find when you do this work for me tomorrow, if you do it more than one way, they come out pretty darn close together. Okay? Now I'm just going to tell you, Dr. O may make you do it the whole way. So make sure that you're clarifying, is a shortcut okay for him or does he want you to do this? Okay. The short formula estimates the PO2. If you do the long formula, you're getting the actual PO2. But like I said, you'll see tomorrow, they're pretty close. Okay. So for my test, it won't matter because there'll be the right answer either way. Like it'll be on the money however you're going to do it. So I don't really care how you do it. There you go. Short formula. So if you want to work it out, we've done this before, right? Does anybody need to practice this today? Because we have it coming up in the lab tomorrow. You've done this all before. Okay? See a bunch of shaking heads no. Are we good? Okay?
I think I did this about almost 12 times with Ms. Polly's mini clinics.
Yeah, that's right. So you should be really good. But we're going to do some tomorrow just for giggles while you're waiting your turn on your bed. Okay? Now, I also can look at the alveolar arterial oxygen tension difference, which is simply stating if I have oxygen on one side, and where is it in relationship to the other side, okay? So this is the difference between oxygen tension between the alveolus and what's actually in the blood. And the difference is a measurement of diffusion capacity. Because again, oxygen should diffuse, right? So if I have a really high number, I'm not diffusing, okay? So the formula is very simply little a from the big A. So P big AO2, subtract little AO2. That gives you your arterial alveolar oxygen tension concentration, or we call it the AA gradient because it's nicer. AA gradient. Okay? So normal is about 25 millimeters of mercury on oxygen. On room air, it's less. Now, what this rest of this message is saying is that if you have a value that's more than 300, you are approving a shunt. Because I'm not offloading any of that oxygen. Does that make sense? Okay. So AA gradient should not be really high because that proves I have a shunt. And that's what you're going to use it for. Does that make sense? Normal shunt is about 20% on room air. Can be up to 65 if you're giving them 100% oxygen. Okay? That's normal. Now, if I don't want to bother with all that, I actually can do an estimated shunt. And that's very simply taking the AA gradient and I divide it by 20. I multiply that by 100, I get a percentage. Normal shunt is about 5%. A normal shunt comes from blood flow that is not feeding the whole body, but perhaps a particular organ, like your thespian vein, for example, in the lungs. Okay? There's a little bit of blood that's around in there that's not participating in our gas exchange, that's literally feeding other organs. Okay? And it's about 5% of normal anatomy. So what to take away from this, other than what causes respiratory failure in 2 types? Or you can have a mix. The formulas for the math, and the normals for shunt, and for AA difference, or AA gradient. Okay, that's what I want you to take away from here. Here's an example if you wanted to work through it. You've all said you don't, because you're gonna do it tomorrow. So, common criteria for initiating mechanical ventilation. This slide is very important. Our vital capacity at less than 10. One book says up to 15, so I put it there, 10 to 15 mLs per kilo. If you have an AA gradient of more than 450 while using 100%, that will get you to buy a tube. If you've proven hypoxemic or hypercarbic or a combination respiratory failure, if you have an emergency, someone lost their airway, they went to the seafood buffet and have lost their airway, you're gonna get to buy a vent for that. You were shot in the face, you're probably buying a trach for that. You were in a car accident, some other emergency, okay? If you have a dead space ratio of more than 60, and that's just where you're taking the dead space that you have divided by the tidal volume. We'll do this in a couple of days. Normal here is about 25 to 35%. If a patient is unable to maintain a MIP, okay, negative 20 is bad. Normal is about negative 100, depending on how healthy you are. If you have a PEP, which is expiratory pressure, or an MEP, which is what we do too, of less than 40, that's not good. Normal is 100. A rate of 35 or more. Now, you and I both know that nobody has ever been intubated just because they're tachypneic, right? You'd have to find some other proof that they need help. Because there's a lot of really excitable people out there running around breathing fast. I'm not running around dropping tubes down everybody, because guess what? If you're super anxious already and I throw a tube down you, what happens? You're gonna go bananas, right? So that's not a sole indication, but if you partner it with something else, it would be a reason to intubate. If you have a PF ratio, which is the PaO2 divided by the FiO2, and if you forgot the formula, here the FiO2 is as a decimal. Okay. Remember, a PF ratio of less than 100 is ARDS. Should be more than 300. So if the numbers are high, you're good. And again, we're going to cover all this coming up again. Less than 100 is ugliness, and we don't want that.
So is the less than 300 that's mild and less than 300 is moderate?
So when you think about your Berlin scale, we talked about for ARDS, 300 and above is normal, 350 and above, some books say. 2 to 300 is mildly ARDS, okay? 100 to 200 is moderate, less than 100 is severe, you're dying, okay? The North American European Conference has a little bit different scale, where they talked about acute lung injury, and then it got into ARDS. So just be aware there's two different scales out there. All right, let's talk about our ventilator vote of the week, and then you guys can go home. We've already talked quite a bit about SIMV. So what is so magical about SIMV? What does it add to any other mode, whether it's ACVC, ACPC, PRVC, pressure support, okay? Okay, it's a volume cycled mode, except for in the spontaneous breath. If the spontaneous breath is using pressure support, well then it's pressure cycled. The boards consider this a weaning modality, or Brian's what I was saying yesterday is a shared work, okay, where you and I are helping each other. If you put this on a real patient, they'll probably go bananas. Because it's not very nice. And the SIV part of it stands for synchronized intermittent mandatory ventilation, which means the vent is supposed to be smart enough to know, here's your machine breath, and then you're going to take a breath from me in a second now, so I'm going to wait, and I'm going to let you take that spontaneous breath. And then I'm going to wait again until it's my turn again. Well, that's not what happens on most patients, because they're breathing too fast. So that IMV timing window doesn't have enough time to jump down to where it needs to be to have the breaths be sensible. So you still can stack, although it's nicer than the old school IMV mode, which meant you were stacking breaths all the time. Okay? We don't do that anymore. Ideally, the ventilator is going to sync with the patient. But again, and write this down, if they're super tachypnic, all bets are off. Super tachypnic, they're not going to dig this at all. And I wish to baby Jesus that when I was in college, somebody bothered to tell me that the only variation of SIMV is because somebody got smart enough to give you pressure support. Doesn't that make it simple? Instead of thinking SIMV VC, SIMV PC, SIMV PRVC, SIMV VC plus, who cares? It's just pressure support. You just gave them some, okay? Everybody gets all freaked out about the language. So because of the SIMV, we talked about this last week too. I lost my bird. My little pretty control breath. Get one every so often, okay? If it's assisted, I ask for an extra one, but it looks the same, it walks the same, it's the same exact breath, okay? Spontaneous, however, so that breath could be little, it could be monster giant, because it depends on how much of that pressure support the patient wants to use. Okay, and you guys tried this, and I hope next week or even tomorrow, if you guys want to get on one of the vents, I'll change out the circuits. I was gonna do it last time we had blood gas stuff everywhere. You guys know from playing with the BiPAPs, right? If you put that in your mouth and you had a IPAP of 10 going, you got well over 1,000 ml tidal volume, right? Big old breaths you're getting. Didn't take a whole lot of effort, okay? So these are twin breaths. Mandatory, patient's not helping. Mandatory helped a little bit because I wanted an extra one, but it looks just like the one I just got. If I have a spontaneous capability with pressure support, like an SIMV, I have a machine breath, then I have an assisted breath where the vent goes, oh yeah, here she is, she wants a breath. And then guess what, I take a third breath, that one is a pressure supportive spontaneous breath. So it can look different. And even the flows can be different, and we'll get into that graphically later on. Okay, does that make sense? And like I said, tomorrow remind me, and I will come around to you individually and show you what the various breaths look like on a mode like that. Okay, where you have SIMV capability. Most of the patients that we see in the ICU nowadays either want a lot of help or they want to do it. And there's really nothing in the middle. So we don't often SIMV people at the bedside anymore, at levels at least. You guys can tell me what you're seeing out there. Like I said, the one patient that I had that I actually put on SIMV deliberately, I haven't done that in forever. He was the only one who liked it. So, but for the boards, it's a perfectly agreeable weaning modality. So stuff you can set, it's all the stuff that you're used to, okay? So if I am in SIMV with volume, I set a tidal volume, I set a rate. I either can inadvertently set the flow or I can set the I time, the FiO2, PEEP, and pressure support is my new development, okay? Rise time helps me get the breath faster. And the other new thing I get is the inspiratory cycle off or expiratory sensitivity. Inspiratory cycle off, exhalation sensitivity, depending on the vent, okay? Pause time you can set, although we discussed a lot of reasons why I don't think it's necessary unless your patient's out. And of course you can set sensitivity. Now, the pressure part of this. So again, we talked about this a moment ago. The spontaneous pressure supported breaths are cycled differently than the volume breath that's in that mode. Okay, so if I have SIMV/BC, so I'm setting a volume, right? I'm setting a pressure support for the patient to bounce into when they want to breathe on their own, right? Volume control breath is a volume cycled breath. Hit the volume, the machine stops, they're allowed to exhale. Okay? With me so far? If I'm bouncing into the pressure supported side, then those spontaneous breaths are actually pressure cycled breaths. Hit the pressure I get, I can exhale. Better demonstrated tomorrow on the vent. Okay? Now, I can use pressure support by itself as a modality, but there is no set rate. So make sure you write this somewhere. No set rate. And that's the primary difference between pressure control and pressure support. And this is where it gets a little wonky because I can use pressure support. I've been telling you for 2 weeks now. You can do that with another mode like volume or pressure, right? But I also can do it by itself. Okay, and I will show you that in the coming weeks. We use pressure support to help us on spontaneous breathing to get past all of the junk. Gotta get past the mechanical dead space. That's what it's for. Okay. Now, factors that affect tidal volume and pressure using pressure support ventilation is the pressure you set, right? So whether it's pressure control and I've set a rate, or it's pressure support and I didn't set a rate, how stiff your lungs are has some bearing on the size of breath you get, right? If I have a very stiff lung happening, I'm going to get the same pressure, but I may not get the same volume. And I'll demonstrate this again for you tomorrow, okay? We did it over there when I oriented you to the servo, and I had you squeezing the lung. Okay, what happened to your volumes? They went crappy, right? Now, conversely, if the magic actually happened, maybe they're in bronchospasm and you gave them a whole bunch of bronchodilator, their lungs really opened up. Well, then that pressure control, they can actually have a monster breath with that. So you may need to turn it down. So that's the key with pressure control, okay? Tidal volume also is affected by how long of an eye time you get. So in a pressure controlled mode, if I want you to have a little more volume as a result, I can give you a little longer eye time. Might help. Okay, these are some of the tricks of the trade you will learn. Any questions? Mind blowing, huh?